Thank you, the professor, for your presentation. I don't have too much time. I like just to present some case. I think it's a very interesting case to discuss another presentation. My first comment, no, sorry, just a minute. My first comment. Okay, my first comment is when I start the endovascular technique to treat the aneurysm, the initial case is the basilar tip aneurysm or terminal carotid, because it's very easy to navigate. But the question is, when you put the coil, it's depending of the size. It's different to understand the small aneurysm to the medium or big size aneurysm, because the aneurysm every time grows because it's flow dependent. The inflow is the most important. And just a minute. The endothelialization is not early 6 weeks. And this endothelialization is not easy or totally complete in bigger aneurysm. This is the reason with this regrow the aneurysm. And the coil in sac, you are more pressure in the sac when you are coils. The flow come here, the pressure is different when you are the coil. This is the reason when many aneurysms regrow after coiling. This is one point. This is the standard medium aneurysm, the balloon remodeling technique, and treat it. This is good, but sometimes the patient recanalize. One special case, this patient have dissecting a thrombus of both carotid, right and left. And they have a small aneurysm in the top basilar top. You have the posterior communicant artery, you have the middle cerebral artery, you have the posterior communicant artery and the middle cerebral artery. If you put only coils with balloon remodeling, I have sometimes problem too, when you deflate the balloon, the coil migrate. Why? Because you change the anatomy. The material of balloon is very stiff. And when you deflate, you change the anatomy of this. This is the reason I prefer to use the stent, standard stent. This is the aneurysm. This is the work projection. First of all, I treat it to navigate in the posterior cerebral artery to place the balloon or stent. Secondary, I check in the posterior communicant artery and middle cerebral artery. I coiling only one stent. And this is the result. And the occlusion. This is another case. I decide to use double stent. Why? Because sometimes I don't know where is the initial part of the neck. I don't know if it's here or it's here. This is the reason when I present the case René Chapeau or present the case Juha Gula. Some case when you occlusion the vessel, posterior cerebral artery, with very close to the neck is efficient. Sometimes it's efficient, this treatment. The risk is the infarct. but it's efficient. In wide neck aneurysm, I prefer to use double stent. This is the CT reconstruction. Every time I need open cell here with balloon, this is axial view, and this is the control, a good result. Okay. This is another case. Why I need to use is 3 months mild, acute phase, Henty-Hughes 5. I use 8 coiling with a micro catheter only and fiber coil to the neck. This is the only treatment for this. This case is a case treated by myself in 1994. And that moment is the early moment to treat it with the GDC. This patient, 1995, sorry. This is the clinical symptom. And you see in the scanner, CT scanner, you have the hypodensity in the brainstem and mesencephalo, and dilatation of the temporal ventricle. I decide in this moment, because this aneurysm is giant. This is the point of rupture. This is the mass effect in the perforate branch. At this moment, and this is the inflow. The first treatment for me is to place one balloon in the dominant vertebral artery and close this artery to decrease the flow in the aneurysm. 1 week later, I catheterize the aneurysm and coiling. Okay, and this treatment is some satisfactory, but every 6 months, the patient come and reopening the neck. Finally, I decide to close both the second vertebral artery with a balloon and reverse the flow in the vertebrovascular system. This treatment is performed in 1996. This is the patient in 2005. Totally cured and no reopening the aneurysm. Reverse the flow. Another patient, 30-year-old. This patient is from Colombia, Medellin, with Dr. Vargas, coiling. Finally, I decide to close the neck and the tip of basilar artery. Look this. And you have the collateral circulation. The patient is stable. No regrowth. No flow diverter. No web. I like my presentation. No talk everybody of web device. I think the web device is nice device, but you are many recanalization. Another patient have a P1 and basilar tip aneurysm. This is the posterior communicant artery. This is the giant aneurysm. This is the CT scanner. This is the neck. I decide to treat it only to coiling the posterior communicant artery and posterior cerebral artery. This is the collateral leptomeningeal circulation, and the patient is totally occluded, stable, more than 15 years of follow-up. And finally, it's a difficult case because I have the mid-term follow-up, but also it's possible to see what is the evolution. 53-year-old. This is the MR. You have the mass effect and gliosis in the thalamus mesencephalo with giant aneurysms. These giant aneurysms have flow here or thrombus here. This is the initial angio. The P posterior cerebral artery and superior cerebral artery born in the end of the aneurysm, and the posterior cerebral artery and superior cerebral artery stay safe of the aneurysm. This is partial reopening thrombosis aneurysms of serpiginous. I decide to use some Leo stent because it's different size, the distal part of the initial part. I put 7 Leo stents. This is the first, okay, this is the stent. But this is the evolution. Initial, presenting 1 month, 2 months, 6 months. Very good picture. The patient is stable, but this is the 2010, February is the final control. 1 year later, the aneurysm regrowth after 7 Leo. I decide, this is the angio, you are the endolink. In this point, also in this point. Look the endolink, look the contrast here. At this moment, the discussion is bypass, more flow, overlapping, papilline at this moment, proximal occlusion, holidays. I decide to treat, to put some more Leo stent to cover this endolink. But at the procedure, the Leo stent produce 1 occlusion of the posterior cerebral artery. I decide to perform a balloon remodeling to open this, but in this moment I rupture the end part of the junction of the posterior cerebral artery, and I decide very quickly to close this vessel with coiling to preserve the patient, to stop the bleeding. 1 week later, this is infection, or two weeks later, and the patient death because have edema and ischemia. Okay, it's only 2%. Thank you for your attention. 2%. The different situation, and thank you very much to the panelists to help me to neuroimaging. Thank you.
Thank you, Professor Luis. So it's time for the floors to our questions or share idea or experience. Does anyone have questions?
Any?
I think there was one or two in the chat. Let me get.
Oh, yeah.
Did you see any in the chat there, Warlick?
Okay. So the first questions from the, I guess, Dr. Mario is the question for Professor Juha. He asks, like, in which cases do you decide to do a bypass before clipping?
Bypass doesn't help in any way in basilar bifurcation or basilar supracerebral aneurysms, but maybe in the P1 aneurysms you might do if you are trapping the aneurysm. So this is
那么这个问题是关于刘海教授，是不是需要做搭桥？
I have been helped by the world champions in bypass surgery. So, but I don't see any indication to do in basilar bifurcation or basilar scar, supracerebral artery aneurysms. I don't see any indications. In the absence of treatment, in the 3 last lectures, there was no microneurosurgery. It is still existing and good treatment for many of these cases. So you will find some of the last Mohicans to do good microneurosurgery, and also younger virtuos who can do and clip basilar aneurysms. One of the drawbacks of endovascular surgery is that it's extremely expensive. So we are now, what we are speaking, this is first world surgery. So I was working in Nepal, now in China. So who is coming to endovascular surgery? Those who have money. And those who have no money, they might have open microneurosurgery. In Nepal, it was so the people didn't have money even for a clip. For a clip is $300 to $500. A stent is 100 times more. So if you push several stents, so you quickly push money for a car or for a house inside this large aneurysm. So this is a question, and you should think about it, because, for example, in China, you have 4 million aneurysms running around, 4 million people with aneurysms. So if you treat them all with these expensive means, so it is huge number of money, and the same counts for every big country. And the bigger the country, the more poor, the worse is the follow-up. So in most big countries, you don't have any follow-up of the cases. So follow-up means that you have 100% of follow-up and many years ahead. So then you know all the complications. I have been close to 50 years in neurosurgery, and I have seen all kinds of things, weird things in open microneurosurgery, of course, but also in endovascular. So it is not so that easy case like I hear in many congresses. It was very good to hear these honest endovascular lectures telling about complications and difficult cases. Thank you. I was talking too much, and I have been talking 30 years about endovascular surgery. So I have been involved too much maybe in that. I can only tell that I was getting endovascular surgeon in mid-70s, and Guglielmi is my good friend. Thank you.
Thank you.
Thank you, Professor Juha. And next questions, asking Professor Rene Chappell is that when there is an edema, I believe in the endovascular case, do you need to use any medical treatment? Or which type? I guess that's the question. So,
You know, I'm not sure if he's here. He may have stepped. You may have stepped away.
If Dr. Luis or Dr. Gurula can answer that instead of Professor Rene.
Steroid. The patient I treated by steroid.
Oh, steroid.
And you, Gula? Micro.
Is he here? I'm not sure. Oh, yeah, he's here. Yeah, unmute there. Okay, I'll ask you to unmute. Okay. Having trouble with the unmute there.
Yeah, sorry.
Okay, there you go.
Yeah, sorry. So we have the steroid, of course, standby, but I only use it when the patient has clinical signs of edema. I don't go on the images because I did it when I was younger and not so experienced, and the patient got psychiatric symptoms afterwards. So then I learned that the steroids has this side effect also. So I don't use it just in a preventive fashion, just if it is clinically motivated.
I have one question to Professor Bing. Why do you perform, or if you have experience to perform the bypass in the posterior cerebral artery?
Yeah, actually, my experience is similar with Professor Juha. For the basilar tip aneurysm, it's no need to do some bypass, but the PCA sometimes it if you occlude the proximal part of the PCA, you may need some bypass. But before you treat it, you can use small balloon to occlude it and test the collateral blood flow. If it's tolerable, it can tolerate the balloon occlusion test. You can occlude the PCA directly. And sometimes I use staged occlusion of the like P1 if it's a PCA giant aneurysm, just as you should in the case, similar technique. But the first stage, I will partially coiling the proximal part of the aneurysm. Then
But the bypass don't work very well.
Because, you know, if it's only PCA territory, mostly the MCA territory and the ACA territory can have some collateral flow from distal part to the proximal part. So normally I don't need the direct bypass.
One question for Juha, please. Professor Juha, well, in my presentation, I talk some comments to the inversion of the flow, progressive inverted flow with the balloon. Why do you please to talk with your clip hydrodynamic clip to progressive inverted flow in basilar territory? You have some comments?
The slow closing clip is extremely good idea, because even in the endovascular surgery, I see in the desperate cases, you have to do desperate treatments. This is occlude the proximal artery, so the slow closing clip is excellent idea. Unfortunately, we don't have it ready. So one Shanghai group is working on it. I have to connect them if they can do it or not. Maybe it is not big market. This is one of the difficulties. If you can sell something that you can sell to 100,000, 1 million people, then it's different. Then you can device you can use seldom. So about the P1 bypasses, so I can mention, I studied all the cases of Dr. Drake and PL. So Dr. Drake was successful in occluding posterior cerebral artery without any infarctions in around 50 cases. So it was interesting. So even in the posterior cerebral artery, you don't need or seldom need bypass, but like Subin said, you can nowadays you can have test occlusion, and So there are many things you cannot do if you cannot find a big market. Good ideas.
But the proximal part of P1 occlusion is dangerous because you have some perforate branch.
Like I told you, Dr. Drake was able to do in big number of cases. So maybe he was good in selecting the cases, but usually if a regular neurosurgeon put the occludes PCA, like you said, so there is an infarction, but some people can do it. Of course, if you go close to the basilar tip, then you have some perforators there, but usually you can do it without.
Thank you. John, finish now?
Okay, very good. Thank you very much, everybody. And Louis, we're going to have another webcast in 2 weeks, right?
In 2 weeks.
Yeah. What, do you have a topic yet?
Yes, a giant aneurysm of the siphon, carotid siphon.
Okay, very good. We look forward to that. And thank you, Ben, for translating it into Chinese. And thanks, Dr. Gao, Yuha, and Morlix. Thanks for your debut as an announcer. Okay, we'll see you in a couple of weeks.
Thank you, thank you, thank
Okay.
you, everybody.
Thank you. Bye-bye.
Bye-bye.
Muchos